Have you ever taken care of a patient with ruptured esophageal varices? Have you ever accidentally dropped a jar of spaghetti sauce in the kitchen? Well, they make about the same kind of mess, except for this comparison to be equal, you need someone to keep crashing down jars of spaghetti sauce on you about every minute. I know what you did if you have taken care of a patient with a ruptured esophageal varice. We all did. Oh, anytime we think about it, because it's such an unforgettably horrible experience. These patients are very difficult to take care of. And in the transport environment, I don't trust patients with cirrhosis any further than I can sling a piano because I'm terrified that they've got esophageal varices and that they'll rupture during transport. So let's back up and talk about it a little bit. The cause of esophageal varices, first of all, they look like hemorrhoids in the esophagus. Here's a picture I actually found on Instagram from a gastroenterologist. And what causes them is a backup in the portal hypertension. So the two most common causes are alcoholic cirrhosis and damage to the liver caused by hepatitis. And so the hepatic vein filters about 1.5 liters of blood per minute. And when that backs up, the closest veins that also back up are going to be those distal veins in the veins in the distal esophagus. And they look just like hemorrhoids, but only in the esophagus. And patients who have these have about a 10 to 20% chance of bleeding with every year that they have this pathology, and it just continues to go up. And about 50% of patients will have a bleeding event within their first 5 years of diagnosis. Now, what happens with these patients is they bleed and they bleed like crazy. And so it's very difficult to manage the airway of these patients and to maintain hemodynamic stability because think about it, that vein is filtering 1.5 liters per minute. That's the potential for bleeding that these patients have. And so when they rupture, number one, the physician, this isn't placed by nursing, the physician is going to place something called a Blakemore tube. And I want you to think of it as a tourniquet on the inside of the esophagus, right? It's this big, long, hot dog shaped tube that we drop into the esophagus. There's a teeny tiny balloon at the bottom that goes in the stomach, and then the lower esophageal sphincter clamps in between the actual tube that provides the pressure on the esophagus and the tube that the balloon that goes in the stomach to hold it in place. And so it exerts pressure against the inside of the esophagus to hopefully dampen on that bleeding so you can whisk this patient off to the GI lab and the gastroenterologist can go in there and clip these varices, these esophageal hemorrhoids essentially, to get them to stop bleeding. So in the emergency department, the physician places that Blakemore. Us nurses are super busy working on resuscitation with blood products. Every single blood product in the hospital, you're going to need it for these patients. We just dump blood into these patients. Now, if I have a patient in the transport setting and I know they've got a history of cirrhosis, maybe I notice that they have caput medusae on their abdomen, right? Those are those big spidery veins that we see on their belly that they tend to develop in patients with chronic liver failure. There's a few things I'm going to do. Number one, I will not let them throw up, right? Even if they're not nauseous, I'm going to give them a prophylactic dose of an antiemetic to prevent them from becoming nauseous because if a patient with esophageal varices start throwing up, that's really going to increase your likelihood of rupturing one of those varices. Number two, I'm going to let them maintain a position of comfort and sit up. I don't want them laying flat, which is going to increase that pressure on those esophageal varices, and it's going to increase the chances of them becoming nauseous. And finally, I'm going to keep these patients from increasing their blood pressure, right? I want to keep their pain under control. I want to manage these patients really well overall, so I reduce the likelihood that they're going to start bleeding on my watch. So there you have it, esophageal varices. What's been your experience?